Morning, everyone. Thank you so much for joining us for the Cardiac Initiative, for the Cardiac Community Meeting. We are so excited to be here, and there's so much to talk about. So I think we need to talk about a little bit about why we're here. I think everybody's well aware that the heart is a muscle too. Linda's made that abundantly clear over the last 10 plus years. So now we finally got some information about the heart, and we're continuing to dive deeper into the heart. We're going to have discussions around imaging, around rhythm, around medications, around new efforts, around all the things that we need to know about the heart. We need to know why the heart is impacted, how it's impacted by new therapies that are maybe good for skeletal muscle, and how does that impact cardiac muscle, if at all. And if it doesn't, then what do we do about that? We need to know how to evaluate the heart in clinical trials and with new drugs. We need to know when the heart fails, what are our therapies for heart failure? Do we use medicines? Do we have LVADs? And where do we go with transplants and enlisting guys for transplants who need new hearts for heart failure? So with that, I think we'll get started. So our first speaker, we're joined by an esteemed panel. So we have John Soslow, who is here from Children's Hospital Vanderbilt. We have Andreas Barth, who we're so glad made it, from Kennedy Kreiger. We have Linda Cripe from Nationwide, and Tim Cripe from Nationwide, and Chet from Cincinnati Children's. So we'll start off with Jonathan, who's going to talk about cardiac imaging.
Great. Look at this. It's very fancy. I'm not used to having a mic like this. Thank you very much for the invitation to speak. Thank you, Kathy. Thank you, Pat, and thank you, PPMD. And also thank you for setting up the cardiac care conference that we had in March, which a lot of what we're going to be talking about, or at least what I'm going to be talking about, is reviewing some of the things we discussed as a group there. It was really very nice to get together and talk about the heart and Duchenne, and I think we got a lot of things accomplished. So I'll be talking about cardiac imaging. I have no disclosures, but we'll be discussing the off-label use of gadolinium contrast. So we'll talk about imaging modalities, which will focus on echo and cardiac MRI, which are the two most common that we use. We'll talk about cardiac imaging and outcome measures and how they relate, and some of the research that's going on. I'll try not to use technical terms. My dad is a pediatrician and used to always say that doctors put on priestly robes and use medical jargon, and as soon as people figure out what they're saying, they change their medical jargon so people can't understand them. But we will do our best not to do that in this conference. I do want to define two terms that will be throughout my slides that I have trouble changing the way I speak of them. So LVEF is left ventricular ejection fraction. It's a measurement of heart function, or how well the heart is beating. And late gadolinium enhancement is a measure that we use on cardiac MRI to evaluate for scar formation. All right, so we'll jump in and talk about echo, which is pretty much the standard in pediatric cardiology imaging. It's quick, it's easy to obtain. We get great anatomy assessment, we get great functional assessment. But there are some limitations. So when you look here, we use geometric assumptions to evaluate ejection fraction on echo. What does that mean? It just means that we assume the heart is a certain shape and that it's moving equally in all places, and that's not always the case, especially in Duchenne. And so some of those measurements can break down a little bit if patients have sicker hearts or if their hearts are shaped differently. We also don't get tissue characterization from echo, so we can't look for scar. And as you probably know, we sometimes have limited acoustic windows. That means we don't see the heart as well as we'd like. So in this patient, it's one of my patients with Duchenne. This is a beautiful image. This is the left ventricle here in cross-section, and you can see all of the parts of the wall, the myocardium, the heart muscle is moving very well. It's contracting well, and I can get great measurements on this and get a sense of what the function is very, very well. Unfortunately, a lot of times this is what we see in our patients with Duchenne. They just have worse windows for a lot of different reasons. And so here's that same, should have figured I would mess that up pretty quickly. There we go. Here's that same image. This is the short axis, but I can't measure objective measures very easily here. I can't even really tell you what the function is. I can just say that it's not normal. So that because of that, we've moved to cardiac MRI in a lot of patients, and it's become a mainstay in our clinical care and in our research. And there are no concerns with acoustic windows, so we get really nice pictures. We get a very accurate and reproducible functional measure. So what we do is we take the heart and we just put a slice all the way through it, and then we manually measure these slices and put them back together and get function and volumes. So it's very reproducible, very accurate. It's pretty much the gold standard for all of pediatric cardiology for functional measures. And we can also do tissue characterization, which we'll talk about a little bit later. There are challenges with MRI. For anybody here who's had an MRI or had a child who's had an MRI, it's not the most comfortable thing to be in an MRI scanner. We try to make it as comfortable as possible. We need you to hold your breath most of the time. We can do free breathing images, but our pictures are better if you're holding your breath. Really, you can't move very much or else it messes up our pictures, and heart rates can affect our imaging. So not everyone can undergo MRI. How do these two relate? How are echo and cardiac MRI when you compare the two? Well, a lot of us have done this work. This is some of our data from a couple years back. Essentially, the echo measures, the multiple different measures we use are on the y-axis, the MRI is on the x-axis. And when these points line up together and to make a line, that means good correlation. And when these numbers are closer to 1, that means good correlation. That means that they're giving you the same number, essentially. And as you can see from most of these numbers, these really aren't very good. So these are at best moderate, which means that, that they're not giving us the same number. And these are MRIs done pretty much the same day as the echo. The two best, which is now what we measure routinely on our echoes, were a lot better, but still had some issues and were not always measurable because of our imaging windows. So these work. Echo is great for clinical screening, and it's great for surveillance, and it's great in patients who you can't do an MRI in. But if you need to detect really subtle changes, so if you're doing a research project and you need to know, did things change a little bit over time, probably MRI is better, especially in the older children and young adults who have tough windows. We're not the only ones who have looked at this. So Brunklaus et al. Looked at this and showed that fractional shortening by echo and LVF by MRI had only a moderate correlation. Chris Spurney looked at this and showed that echo is not that reproducible, probably because of the imaging windows in Duchenne, and showed only a moderate reproducibility here. And then Sujatha looked at this and showed that echo images were suboptimal in 40% and only weakly correlated with MRI. So what else can we get from MRI? So there are really a lot of things that MRI can do beyond just function, and late gadolinium enhancement is the biggie. So this is an autopsy specimen from a patient with Duchenne from years ago, and you can see here these arrows are pointing at scar formation in the free wall of the heart. And so we know that boys with Duchenne develop scar in the free wall of the heart, and that this tends to progress to involve more of the heart and then go to eventually the septum and to the right ventricle. So this is that same picture we looked at before where this is the left ventricle here, this circle. And we can give a medicine in an IV, a contrast, and we can wait about 10 minutes, and that contrast will be attracted to areas of scar. And we can image that scar using late gadolinium enhancement, and it lights up here. And we know that that scar is visible when it gets large enough on these, using this imaging technique. And we know that younger patients tend not to have scar, and older patients with worse LVF tend to have more scar. And we know that from this study by Tandon et al. That the majority of patients they develop delayed enhancement before they develop dysfunction. So you have a heart that looks good, and then you start to develop scar, and then that scar seems to expand, and that is likely the cause for most patients of their heart dysfunction, that they have more and more scar, less and less muscle. We also know from this paper that most patients did not decline if they didn't have scar, and most patients with scar declined pretty steadily over time. But there are limitations with this method. So we need normal myocardium. We need normal heart muscle in order to evaluate it. It's really only subjective or semi-quantitative, and we don't like that. We don't like subjectivity when we're reading MRIs and when we're looking at studies, because it means you can get different answers with different people looking at it. We also believe that Duchenne is a diffuse process, right? Every cell has this mutation. So the idea that we might be missing some of this diffuse scar is important to us and makes us think that we're missing earlier findings. And so because of that, in this disease and in a lot of other heart problems that we take care of, something called parametric mapping has really gained a lot of acceptance in pediatric cardiology and in adult cardiology. And I'm not going to go into the physics of this, but essentially we can use what my boss says look like weather maps to evaluate scar and edema in the heart. And so native T1 and ECV both increase if you have edema or inflammation and if you have scar. This is a healthy control up here. They have no late gadolinium enhancement, and they have normal native T1 in the mid to high 900s and normal ECV under 0.28. This is a Duchenne patient with a very classic pattern of scar formation here in that free wall like we talked about. And their T1 is elevated and their ECV is elevated, and you can see the same pattern that we see in the late gadolinium enhancement image. This patient is a patient without any scar with Duchenne. And these are the ones that we're interested in. And so this patient had normal function and no scar by the kind of more standard methods, but the T1 is high, the ECV is high, suggestive of early scar formation, early diffuse scar formation. And indeed, when you look at a cohort of a larger group of patients that had no scar by delayed enhancement, you can see that the Duchenne patients have higher T1 and have higher ECV, and we seem to be able to detect those with normal heart muscle and those with abnormal heart muscle and early changes. And so we report this now in our cardiac MRIs, and a lot of centers do, and we will be a little more aggressive in patients that have earlier findings of scar from these parametric mapping images. The other thing that we use a lot, especially in research, a little bit clinically, is something called myocardial strain. This is deformation of the myocardium divided by the original length. And that's the most physics that will be in this talk. I'm not going to go into any more detail on that. The important thing about strain is it's a subclinical marker of function. So we think that, or we have shown that, it changes before left ventricular ejection fraction changes. So we find these changes earlier. There's a bunch of methods of calculating it. But if you look at the data, and Conhor has done quite a bit of these studies, this is normal controls. These are younger patients under 10 with Duchenne that even early on, when everything else was normal, their strain was abnormal compared with controls. And as you progress in these different, they categorized everybody based on age and ventricular function and delayed enhancement. As you progress down these categories, they each have worse strain than the prior. The strain seems to worsen with age pretty consistently, and Conhor showed that in a different study that serial imaging showed that that strain continues to worsen even in patients whose left ventricular ejection fraction improves. So it's a really looking kind of deeper down into function. All right, so what about imaging alternatives? And there are a couple things that we can use. So CT, MUGA scans, there are a lot of imaging options. We don't tend to use most of those in Duchenne patients, a lot of it for the radiation, a lot of it, especially in younger children, we don't like exposing them to radiation. But echo contrast is one thing I do want to mention, and this is courtesy of Catherine Gambetta, who's here from Lurie. We are working on our protocol but have not started, and they're well ahead of us with this. And so what this means is you put an IV in and you give echo contrast, and it helps you see the heart better. And this is that same picture we've been showing, the circle, the left ventricle, and again, you can see it's contracting, but you can't see it very well. And if you give that contrast, I'm not sure how well it's showing up here, but it'll brighten up the blood pool. And so then you can measure the contrast and use that to do an objective measure of function. And so in patients who may not tolerate cardiac MRI, for various reasons, this is an alternative imaging modality that we can start to use. This is the same idea. Looks like the left one's not going to play. This is the left ventricle in the 4-chamber view, and then you can see that we can't see it as well, and when we give contrast, we can see it much better, and we can analyze those more easily. So outcomes, and this is a big part of what we spend a lot of time, a lot of our day thinking about for a lot of us on this panel. So there are right now no established clinical outcome measures or biomarkers in Duchenne cardiomyopathy. There's no agreement on endpoints for cardiovascular trials. The LVEF and myocardial strain have been used in a couple of studies, but the FDA won't allow that for development of novel therapies, or at least not yet. The other issue is that DMD cardiovascular disease is extremely variable. And so if we enroll 2 patients, one might already be progressing more rapidly than the other, and we don't have great ways to discern that. And so when we do clinical trials in that situation, we have to enroll a lot more patients to sort of make up for that variability. And finally, medications need to be started earlier in the disease for the best efficacy, to make them work better. But if you start it early in disease, a lot of the outcome measures the FDA likes are not really an option for a trial. And that's because they like to decrease death. That's what they want to see in a trial. And in adult studies, that's great. That's easy. They enroll thousands of patients. They follow them for 1 or 2 years, and then they can easily tell if a drug is helping or not. But we don't have that luxury in Duchenne. So it's a rare disease, and we want to start things really early before we see those large areas of scar. But to do that, we would have to do a 10 or 20-year trial if we were going to show death is improved and answer the FDA's questions. So we really need to make the FDA understand that that's not an outcome measure that works, and that we need to have other outcome measures. And we've been working very hard on that, and part of this PPMD meeting in March was having FDA there and explaining that to them, and a lot of us have spent a lot of time talking to them about this. So what we need is an outcome measure that allows us to evaluate the effectiveness of medications more quickly and is accepted by the FDA. What do we have so far? It's limited. And this is a limited overview of that. Echo outcomes, primarily function. So if you look here, this by Corrado et al., those patients without LV dysfunction had better survival than those with LV dysfunction. And this has been shown also in these papers by Schramm and Whitley-Weber et al. LV size by echo seems to associate with improved survival. So smaller left ventricles those patients seem to live a little bit longer and do a little bit better. Age of dysfunction is probably important. This paper by Wong looked at LV dysfunction in patients over 18 and patients under 18. And if you develop it later on, the survival is significantly more, even with very similar rates of decline. What about MRI? Even more limited. This paper by Shaji Menon looked at function and delayed enhancement, so scar formation, and showed that those predicted survival. But again, a very small cohort. And then this patient out of Cincinnati looked at strain and was really interesting. So they found patients with cardiomyopathy and without cardiomyopathy. They age matched them and went back 2 years and looked at their MRIs 2 years before they developed heart dysfunction, and showed that the strain was decreased in those who developed cardiomyopathy, or was worse. And so that there is some ability of strain to predict future changes, and may help us kind of get an idea of who's going to progress more quickly and who's not. There is certainly overlap when you look at these bar graphs, but also certainly something that can help us down the road. What about ongoing imaging research? What are we doing? What are other people doing? The first thing I want to talk about is after that meeting in March, there was a lot of discussion about harmonization. And I think this is really important as a first step. And so right now you can go to Vanderbilt or Cincinnati or Nationwide, and you'll probably get a very similar MRI, but there'll be differences in the way it's done. And then you can go to other centers that's partially because we all work together and talk. And so we are doing similar things. You can go to other centers that maybe we aren't spending as much time hanging out with or talking with at meetings, and they may do a completely different MRI than what we would do. And they may analyze it completely differently. And we really want to give consistent care. It's important for clinical care that everybody gets access to the same techniques and everybody gets the same kind of MRI. And we want more consistent reads. So if you get an ejection fraction in one place and then go 3 months later and get an ejection fraction somewhere else that's completely different, that's not a good thing. And I can tell you that my partners and I all read almost identically, but there are different ways you can read an MRI, and we really need to make that more consistent. The other thing that we need is consistency for research. So if we are going to answer these questions for the FDA, we need large amounts of data that are combined to look at outcomes and to figure this out. And to do that, we need to be doing things the same way. So it's important for a lot of different reasons, and we're focusing on our MRI protocols and analysis right now and working on that paper. And there's also quite a bit of focus that Chet's working on for medications and a whole bunch of other harmonization. I'm going to talk just a little bit about what we're doing, mostly because it's what I know. There's a lot of really good research going on at other centers, but I can't speak to that as well since I'm not part of those. So we have the Duchenne Muscular Dystrophy Cardiac Care Consortium. It's FDA and PPMD funded. There's 7 sites around the country right now, and we are continually but slowly expanding to try to integrate more people with similar protocols into the group. We are currently prospectively enrolling DMD patients to get an idea of what the progression looks like and try to answer these questions for the FDA. And we've submitted multiple grants to look at retrospective analyses and are looking at drug studies. Our goals, I'll read these out. They're a little bit jargony, and I apologize. Identify biomarkers that can be used as endpoints in clinical trials, and then identify biomarkers or genetic variants that predict progression so that patients can be risk stratified when entering clinical trials, thus reducing the total number of patients enrolled. What does that mean? We want to make trials better, faster, and smarter. We want to get trials done more quickly and get medicines approved so we can get them into our patients and start making patients better. And to do that, we need to go to the FDA and get them to understand and explain to them what biomarkers are okay to use for these trials. This is just a very small bit of what we've been working on. This is a composite risk score that we put together from old patient data where we looked at age of onset of LV dysfunction and age of onset of myocardial scar, and showed that assumed that the earlier you had scar or the earlier you had dysfunction, the worse your heart was, and assigned a score, and the higher the score, the worse things would be. And then when we looked at patient survival in that cohort, showed that those with a higher score indeed had worse survival than those with a lower score. So a potential possibility for composite outcomes as we work to do this with the FDA. The other thing we've done is we've looked a lot at progression. And so this is what we call virtual biopsy using our parametric mapping. And I won't go into all the details, but we're looking at edema, scar formation, and then fatty infiltration in these patients. And we've shown that a lot of them have scar, as we expected. More than we expected had what looks like edema or inflammation, making us think that that's part of the common pathway to the heart dysfunction and heart disease. And then some of the older patients had fat infiltration, especially the ones with more severe cardiomyopathy. Other cardiac research, there's a lot of really good stuff going on. University of Florida does a lot of imaging, skeletal muscle, and now cardiac stuff. Cincinnati does a ton, and then Action, which you'll hear more about from Chet later on, is getting a whole bunch of academic centers together. So it's really a good time. I mean, we're working hard at this, but there's just so much more to do. So conclusions, cardiac MRI is more accurate and reproducible than echo for clinical management and research, but echo is fine if you have good windows. Contrast echo is a good alternative, especially in patients who can't tolerate MRI. Cardiac MRI is promising for surrogate outcome measures, but we really need to go to the FDA, and I know I've said this like over and over, and I apologize to be a broken record, but we need to convince the FDA to make them understand that we need different outcome measures for DMD. I want to thank everybody at Vanderbilt, all of our collaborators, and all of our outside collaborators, as well as everybody who's funded us, and especially PPMD for putting this together. So thank you.
John. I think we all understand that it's really important to understand the natural progression before we impact the heart and the disease as a whole with any kind of clinical trials or any new drugs. So all of your work for natural progression is really appreciated. Thanks. One thing that I think, because we have some new people in the audience, strain. Could you talk a little bit about what strain is and why it's important to measure?
Yeah, absolutely. I'm not sure if it's still on anymore. So essentially the simple way to think about it is you take the heart when it's relaxed all the way, and you make a measurement in part of it, and then after it contracts, you make another measurement, and you subtract that difference. So it's like the change. And it's a lot like LVF, except that we're looking at it in a more focused area. And so it's sort of a corollary to the myocardium or the myocytes, the heart cells contracting. And we can look at it in very sort of focused areas. So we can look at this segment and that segment and that segment, or we can look at the whole thing. And when we do that, we find that we see changes earlier than we would if we're just looking at that ejection fraction, which is pretty late findings sometimes as you start to have effects on your myocardium. And so, so the way I think about it is a strain is just an early marker of dysfunction. And so when we start to see strain changes, we can know that maybe there's something going on in the heart, and there's probably some early scar. And in fact, there's a lot of data that that early scar and strain run together. So as you might expect, if you lose some of your myocytes, some of your cells in the muscle, your heart's not going to contract as well, and that's going to be manifest when you measure the strain. So I don't know if that answered your question quite as well as I should.
Does that make sense? Everybody?
Okay, all right.
It did. That was good. Well, we know that the composition of the muscle and the amount of scar impacts the electrical activity through the heart, and rhythm is a product of the electricity through the heart. So Andreas is going to talk to us about the importance of rhythm and rhythm measurement. Thanks.
Thank you very much. Good morning. Thank you very much to PPMD for inviting me and for their tireless effort to help us to understand more about Duchenne and improve the life of patients with Duchenne. So I'm an adult cardiologist and a cardiac electrophysiologist, so I focus on heart rhythm disorders and see patients with neuromuscular disease, including Duchenne. And I'm going to talk today about the risk of arrhythmia, specifically about the risk of arrhythmias in Duchenne, what we know and what we don't know so far, and what options we have for rhythm monitoring to study this problem of arrhythmias a little bit in more detail. I'm going to talk about EKGs, short-term monitoring, which is Holter monitored, and event monitors, and ultimately implantable loop recorders. So starting about the risk of arrhythmias. We know that the life expectancy in Duchenne has improved significantly over the past decades, and it was mostly because of improvement in ventilatory care with invasive and non-invasive respiration. We also know that the causes of death have changed. This is on the left side before 1990. Most deaths were due to respiratory causes, and very few were due to cardiac causes. Now that we've handled the respiratory causes better, we know that the cardiac deaths have become more important. This is after 1990. However, what we don't understand is, are those cardiac deaths due to progressive pump failure, that the heart is getting weaker and you have heart failure that's leading to death? Or is it sudden cardiac death, which is due to arrhythmias? And if it is due to arrhythmias, well, we know we can prevent those with external defibrillations, monthly. Now, if a patient is a very high risk, obviously you don't want an external defibrillator to carry with you at all times. But what you can do is you can implant a defibrillator. And this is a little computer with a battery that's implanted under the skin. It's connected to the heart with an electrode with an insulated wire, which we call a lead. And it monitors the heart rhythm 24/7. And should there be a dangerous arrhythmia, that defibrillator is able to detect that and then deliver therapies. And those defibrillators nowadays, they can be transvenous, meaning implanted through a vein into the heart, or they can be what we call subcutaneous. If you don't need any pacing, you can implant the defibrillator in a slightly different location outside of the thorax, and there is no lead going through through a vein to the heart. And both do the same thing. They detect dangerous arrhythmias, and if they occur, they can be treated. Now, how do we know when to implant a defibrillator? Who is at highest risk? So far, we know that, well, if a patient, this is what the guidelines say about not only Becker muscular dystrophy, but Duchenne, Becker, and limb-girdle muscular dystrophy are lumped together. And please note that these are the most recent guidelines from this year. And the fact that multiple neuromuscular diseases are lumped together shows you that there is really a lack of knowledge, a lack of understanding specifically about Duchenne in this context. What we know is that if a patient ever experiences a dangerous arrhythmia, then no further questions asked, and is lucky enough to survive that arrhythmia, then we implant a defibrillator. Then that patient has what we call a class 1 recommendation. This is the highest recommendation to implant a defibrillator. Now, ideally, we don't want to get there first, that the patient has to experience a dangerous arrhythmia and then be lucky enough to survive this. So we call this primary prevention, that a patient who never had any dangerous arrhythmias but is deemed at very high risk, we want to implant a defibrillator and to protect that patient. And we heard from Dr. Soslow that one of the very important criteria is this ejection fraction. How much blood does the heart pump out with every heartbeat? Normal is 55 to 60%, and if this drops by about half, so to less than 35%, we know that the heart is not only weak, but it's also more prone to become electrically unstable, and those patients should be considered for an ICD. Now, this, in the context of Duchenne, they mention specifically that this has to be reasonable if concordant with the patient's goals of care and clinical status. And there are a lot of, it's not a white or black decision, there are a lot of gray tones in between, and this is why it's important that you see a provider who's very familiar with neuromuscular disease, specifically Duchenne. So what do we know about ejection fraction? We heard that over time, this is the cohort that we have at Hopkins at Kennedy Kreiger, is we know that the heart function gradually decreases over time, and in many patients, it will actually drop below this level of 35%, even at a relatively early age, where you would consider potentially defibrillators. Now, we know that this ejection fraction is the only marker right now that's recommended by the guidelines, but it's a really imperfect marker. We have to implant about 15 to 20 defibrillators to save one life, which tells you that it's really, there's a lot of knowledge gap there, and we really need to do better. And what we have identified is that if you have scar in your heart, as was laid out by Dr. Soslow before, not only does it weaken your heart muscle, but we have found that this scar burden really correlates with the risk of arrhythmias, even at a relatively early stage when the heart function is relatively preserved. And we know that initially, when you have a little bit of scar in your heart, the heart function remains stable, and then it tends to drop at later stages when you have a lot of scar that affects not only, this is the left ventricle, the main pumping chamber of the heart, when it affects more than one segment of the heart. This is where we really are quite concerned. And this is a study that, not specifically at Duchenne, but looked at other forms of heart failure, whether scar burden correlates with arrhythmias. And what all those studies have in common is that, one, if all the dots are aligned on one, it would mean, well, if you have scar or not, it really doesn't have an impact on arrhythmia burden. If it is to the right, it tells you that, yes, the more scar you have, the more likely it is that you develop arrhythmias. And this is really like a common theme in other cardiomyopathies. The more scar, the more arrhythmias. And this study that looked at 88 patients, most with Becker muscular dystrophy, but 20 patients also with Duchenne muscular dystrophy, examined the outcome if you have scar and ejection fraction over time. It looked at hospitalization, death, and ventricular arrhythmias. And those patients that had an ejection fraction greater than 45% and no scar did really well. Those patients that had a low ejection fraction and had transmural scar, meaning the scar that extends across the whole thickness of the ventricular wall, they did the poorest. And then interestingly, if you have a relatively preserved ejection fraction of greater than 45%, but you do have scar in your heart, those patients did actually much worse. So this is where this ejection fraction is imperfect. So if you have an ejection fraction of 35%, but you don't have much scar, I'm not going to be as worried about you that if your ejection fraction is 40% or 45% and you have a lot of scar. So we really have to take into account both over time, and hopefully as we learn more, that our guidelines will ultimately also reflect that. So how can we risk stratify that from an electrical perspective? The first thing that we can do is we can record an EKG. And an EKG is basically a 10-second snapshot of the electrical activity in the heart. Unfortunately, what we know is that there are EKG abnormalities are seen in the vast majority of certainly pediatric patients with Duchenne, and certainly of all the patients, adult patients who I see in clinic. And it really is not very helpful to identify patients who are at higher risk of arrhythmias versus those who are not at risk of arrhythmias. So the next thing is that we say, okay, a 10-second snapshot of the electrical activity may not be enough. Let's look at longer duration of monitoring. Let's look at 24, 48-hour monitoring. Those are Holter monitors. And then if you monitor longer, then it's event monitors. So those are the traditional 24, 48-hour Holters. We seldomly use those anymore with those cables because they have been largely replaced by these more modern devices, which are patches that you usually can apply up to 14 days, but we can certainly do also 24, 48 hours recordings via these patches. And they're very convenient for the patients to wear. They can shower with those. There are no cables that are hanging around, so they greatly appreciate the ease of that monitoring the patients. And you can really monitor them for extended periods of time. And is it useful? Does it really help you? And there's a lot of there are 3 studies that are noteworthy. One is from Dr. Villa's group that looked at the usefulness of Holter monitors, and mostly in pediatric patients. And what they identified is that abnormal Holter findings, such as non-sustained atrial or ventricular arrhythmias, so atrial are arrhythmias that are coming from the top chamber of the heart. Ventricular arrhythmias are the ones that are coming from the main pumping chambers, and those are the ones that are potentially dangerous and life-threatening. If you see those arrhythmias, they're usually associated with a reduced heart function when the ejection fraction is less than 35%, or in older patients. And we know that the age is very important, that over time the ejection fraction drops. So in contrast, you could say, well, if you have a younger patient with a normal ejection fraction, you're less likely to find anything abnormal on a Holter monitor. How long should we monitor those patients? This is a study that looked at 14-day monitors with this, what's called Zeo patches. And they defined as 100% success rate or 100% sensitivity after 14 days. After 14 days, they defined this as 100%. If you monitor only for 1 day, you will find the yield will be less than 50%. So you may miss 50% of those arrhythmias that you would otherwise get with prolonged monitoring of 14 days. Now, if you monitor for 7 days, which is quite reasonable for most patients, you will detect up to 90% of those arrhythmias that you would get with 14 days. So that may be a good compromise where you say, okay, for patient comfort, we don't want to extend it too long. Some patients may be allergic to the patches, and the patches come off, so it can be a little bit cumbersome to wear. But 7 days, most patients do relatively well. Now, you can extend that even longer and say if you give a patient a second patch, because we didn't capture any significant arrhythmias in the first 14 days, you may be able to detect an additional 17% of patients who have significant arrhythmias during week 3 or 4. And then there are some patients who have palpitations, but despite all the efforts, we're unable to capture that arrhythmias. And then we actually go to what's called an implantable loop recorder. This is a little chip. It's about 1/3 of the size of the AAA battery, which is the smaller of the 2 batteries. And we can inject that under the skin over the heart area. And we can detect, or we can record the heart rhythm 24/7 over 3 to 5 years nowadays with the newest devices. And they're very convenient because there are no cables. There can be any skin allergies. Once they're implanted after 2 or 3 days, there's usually no discomfort for the patients. And they can transmit their data. This little device is Bluetooth activated. Via the cell phone, there's an app, and that transmits data to our clinic should there be any significant arrhythmias. And what we're doing with the help of the Department of Defense and co-sponsored by PPMD, we have a study to look at arrhythmias in patients with Duchenne. And we're enrolling patients who have an ejection fraction that is less than 55%, so very loosely defined, that has to be anything but normal, and who are older than 10 years. And usually most of those patients need to have palpitations so that they're eligible to get either one of those Zeo patches or event monitors or loop recorders even. And we enroll all those patients in a registry. Initially, we had planned for 75 patients. We extended this now to 100 patients to get a better understanding of what is really representative in the larger Duchenne community. And the additional aspect that is very interesting in this study is that we're able not only to define who has arrhythmia and who doesn't, but we're able to correlate that with the cardiac MRI. and to create personalized heart models based on the cardiac MRI. And as we have heard before, scar doesn't equal scar. And it's really not only a yes or no response. It's not only how much scar do you have. It's also what does the scar geometry look like. If you have one big patch of scar, that may be very different than if you have little islands of scar and you can form short circuit of electrical activity between those little islands, which we call reentrant ventricular tachycardia. And that can be very prone to developing arrhythmia. So we're taking this information based on the cardiac MRI, creating these personalized heart models, and then putting that through a supercomputer. It's one that the NASA is using to calculate their space journeys. It can take up to a day to get all the calculations back. And we do a virtual AP study that will tell us whether this heart is more likely to develop arrhythmias versus not. And we're still actively enrolling patients, so that's important. So if you have anyone who may be interested, please let me know. And I want to show you some of those expected and unexpected results in the study. One that was unexpected for me as an electrophysiologist was that we found several patients who had atrial fibrillation. And this is an arrhythmia that I usually see in elderly folks, so in elderly patients. If you're 50, 60, 70, no surprise. But to see that in younger patients, that's quite surprising. And it's important to know that atrial fibrillation, which is an irregular rhythm from the top chamber of the heart, so that is not one of the dangerous life-threatening arrhythmias. However, it is still an actionable arrhythmia because you can develop with atrial fibrillation blood clots in the top chamber of the heart. And those blood clots can be carried away with the bloodstream, and they can end up, first vessels that take off after the heart go to the brain. So if a blood clot dislodges, swims with the bloodstream to the brain, what can happen is that you can get a stroke. So patients who have atrial fibrillation, even if those episodes are relatively brief, you really need to consider anticoagulation. So meaning patients need to be on a blood thinner to minimize the risk of having a stroke. And the second, as you can see, the heart rate is very fast during atrial fibrillation. So you need to consider putting patients on medications that slow the heart rate down, that they're not symptomatic. And last, this atrial fibrillation can be a manifestation that the heart is getting weaker. And you really need to review the heart failure medications and think whether there is any optimization needed at that time. And I want to bring home the point with arrhythmias and stroke. This is a relatively recent study from a couple of years ago out of Japan that looked at 19 patients with Duchenne, or 20 patients with Duchenne who were rather young, 19 years old, who had strokes. And importantly, the vast majority of those patients, 8 out of 20, had what we call dilated cardiomyopathy, had a weakening of the heart muscle. And this is also what I experienced in my clinic. The patients who had a stroke have usually have a weak heart function. So you really need to worry about atrial fibrillation in patients who have a weak heart. And only 2 out of those 20 patients, they looked very carefully whether they had a blood clot in their heart. And importantly, only 1 out of those 20 patients had any documented atrial fibrillation. And I bet that a lot of more patients had atrial fibrillations if they had checked. But it's really one of those under-recognized and underappreciated aspects. You just don't think about that in a young patient, that they can develop atrial fibrillation. And that really brings home the point of this remote monitoring in a patient who has underlying heart failure. You really need to think also about atrial fibrillation. This is another wide complex tachycardia, and you see that this is a normal rhythm, a little bit faster at a rate of about 100, 120 beats a minute. And then it goes into something that's very nasty, very fast, very broad. This is one of the rhythms that we are potentially interested in, this ventricular tachycardia that can be dangerous and life-threatening. Now, in this case, it wasn't actually a ventricular tachycardia. It was an arrhythmia from the upper chamber of the heart. It was a pathway that was masquerading as this wide complex tachycardia. And then it degenerated into an irregular rhythm, atrial fibrillation at the bottom. And interestingly, this patient who was young had no symptoms whatsoever. So he had this episode and said, well, wasn't even aware of that. It's hard to believe. Now, the takeaways, arrhythmic risk in Duchenne, that the risk of dangerous arrhythmias increases the lower the ejection fraction, so the worse the heart function, and importantly also with the amount of scar that's in the heart. And we know that we have to take both into account at these days. The medical therapies aiming at preserving the normal left ventricular systolic function, meaning the normal heart function, that's by far the most important anti-arrhythmic medication that you can give. If you preserve the heart function, arrhythmias will be much less of a problem clinically. We know that ambulatory EKG monitoring and EKGs are of limited utility if the heart function is normal, but should be considered if the ejection fraction is less than 50% to detect subclinical atrial fibrillation, and this is why this prolonged monitoring is important, and also non-sustained ventricular tachycardia, which can be a marker of those dangerous life-threatening arrhythmias. And last, we still need to define what are the appropriate criteria for patients with Duchenne. When should they get a defibrillator? Is it really enough to say when the ejection fraction is less than 35%, like in other forms of non-ischemic cardiomyopathy, or do you really need also to have some symptoms? Do you need to document that the patients have runs of ventricular tachycardia? Do you need to do a virtual EP study or look at the amount of scars? So there is more to be learned, and thank you for your attention. I'm happy to take your questions.
Anyone have any burning questions, or maybe we can save the questions for a little bit later, unless anybody has anything incredibly important? See, Andreas, that means you did a great job.
Thank you.
So historically, medications that were used in heart failure for Duchenne have been those that were used in adult heart failure. And we know that heart failure in Duchenne is much different rises from different causes than in adult heart failure. So Linda from Nationwide is going to talk to us about new medications that hopefully will attack some fibrosis and inflammation and scar formation and maintain function, right? Yeah, okay.
Thank you. It's always an honor and my favorite time of the year to come and meet with all of you and to be reinvigorated by your energy and passion and enthusiasm. I think this year is particularly meaningful to me from a cardiovascular standpoint because despite the decades that we've been thinking about cardiac care, I think we finally reached a tipping point, taken from that book written by Malcolm Gladwell with regards to how change occurs. You know, I think change occurs slowly, but then all of a sudden you reach a certain place and you tip over into important change. And I think we've reached that time in the cardiovascular care of Duchenne patients where we've reached important change. And I think you've heard that already from the first two talks. You know, I have to admit that the cardiac MRI talk was more sophisticated than we've had in previous years. We now understand the disease in ways we haven't in the past. And I am absolutely thrilled to hear and have Andreas here because we've never really had an interest from cardiac, the electrophysiology community with regards to the care of Duchenne. And you're going to hear about gene therapy and a really exciting initiative from Chet as we conclude this panel with regards to changes that are occurring and ways that we can implement change in the future. So, you know, that was a long introduction. I feel like I've been at this a long time, and so maybe I have earned my extra 2 minutes. But I do think that we have reached a tipping point, and I'm so glad you're all here to celebrate this time with us. So let's move forward, and off we go. And if I could make the slides advance, that would be really fabulous. Am I pushing the wrong button? No, there. Okay. So a slide I always or frequently start my talks with are why are cardiologists interested in the care of patients with Duchenne muscular dystrophy? And as Kathy mentioned too, it's sort of our mantra over the years, the heart is a muscle too, and an important muscle. And so, I mean, I realize that you guys all think about that because you're sitting in this room today, and so I'm speaking to the choir. But I do think that when we think about Duchenne, not only do we need to think about the implications of the skeletal muscles, but we need to think about the implications with regards to the cardiac muscle. So with regards to cardiac care, the journey has been long, and some of the reasons for the journey being so long is that clinical research focus has historically been on the skeletal muscle diseases, I think many of you appreciate. Silos exist in medical research and medical care that have resulted in a lack of exposure of the disease to cardiologists. And limited cardiac natural history data to guide true patient care. As we've heard from the previous two speakers, we're trying to change that, because the only way you're going to inform good clinical care is to know what's been done in the past, so you can know what you need to do in the future. There's a lot of variability in cardiac presentation, as you can see from the graphs and charts that have been presented. Patients don't behave the same. Even within families, patients, two boys may not behave the same. And so that has hindered our therapies. There's a lot of tremendous variability in center practices, and we are working hard to try to reduce that, as Chet will speak to you at the end. And unfortunately, at this point in time, we have heart failure therapies or treatments to treat the heart, but we don't have any dystrophin-specific approved cardiac therapies. There has been an initiative to define cardiac care, specifically in Duchenne and Becker muscular dystrophy, one by the CDC and one by the American Heart Association. And there have been other initiatives through, as a result of heart failure organizations to define appropriate treatments for heart failure, and some of them have included patients with neuromuscular disorders. So what does cardiomyopathy mean? On the left, you can see that there's a normal heart, and on the right, you can see that the heart looks different. And that difference is that the heart thins and becomes less functional. And that's what the word cardiomyopathy means. And I think it's an important term to understand as we talk about the heart in Duchenne and Becker muscular dystrophy. We also need to understand, what does heart failure mean? And I realize that term failure causes fear and anxiety in most of us, but heart failure is actually extremely complicated. And what it does not mean is that the heart has stopped working. What it does mean is that the heart is unable to meet the body's needs. And heart failure occurs when the heart function is poor. But it can occur when the heart function is normal and you have increased demand. For example, if you're outside in the 106-degree weather and you're trying to go up Camelback Mountain, you may have significant dehydration and could potentially develop heart failure even though you have a normal cardiac function. So the body's response is initially helpful, but eventually it results in harm. People can live for a long time with heart failure, especially if it's treated. I think this is a slide that I also use frequently if you've seen a talk by me before, but it's my favorite slide, and if you understand one thing when you go home at the end of this talk, I wish it would be this one, and it's an understanding of the Dmd Cardiomyopathy, because it's a little different than the heart injury that occurs, for example, in myocardial infarctions. And in this instance, you can see where the red arrows are, that in Duchenne, as John so eloquently presented, the injury occurs in the subepicardial region on the outside surface of the heart, as you can see in the pathology specimen on the left. On the pathology specimen on the right, you can see that blue staining occurs also on the outside surface of the heart and represents that scar tissue or fibrosis that occurs. So it's a little different than what you see in myocardial infarctions, which occurs on the subendocardial surface on the inside regions of the heart. Here is a treatment algorithm taken from one of those care consideration papers by the CDC that we talked about earlier. It is not intended to, I didn't put it up here to have you read it extensively. You can definitely get the reference, or I'm more than happy to provide it to you in the future. But it provides guidance with regards to how we think about the disease and how we treat the disease with regards to when care should be initiative, which we do like everyone to see their cardiologist at the time of diagnosis for a variety of reasons. One, to get to know your cardiologist, and to get baseline testing done. And as Dr. Soslow just mentioned, there is some imaging consensus in the care summaries, but we have a lot still to learn. There's no specific consensus with regards to optimal imaging modality, whether that be echocardiography or cardiac MRI. However, there is a very, very strong preference for cardiac MRI imaging. And we also recommend that when there's a wide variation in the onset of dysfunction and variable changes in the myocardium as early as 6 years of age. So we do recommend cardiac MRI or imaging as early as possible to try to identify changes that may occur. General imaging recommendations include imaging at the time of diagnosis with initial cardiac functional assessment by age of 6, definitely imaging prior to dysfunction, and annual functional reassessment. And with dysfunction, it's reasonable to increase the frequency of assessment per provider. There's a variabilities with regards to the assessment. Echocardiograms remain the mainstay of functional assessment, and when feasible, however, MRI by the age of 8 to 10 years, and gadolinium contrast MRI may not be required with each MRI, though we definitely from the previous talk have seen the value in that. Now let's talk a little bit about some treatments. And unfortunately, current cardiac treatments are not dystrophin specific, and that's really what we ultimately need is a dystrophin specific therapy. Hopefully gene therapy will, or some of the other therapies that are under development will provide that. But the goals are to improve survival, slow the disease, and to alleviate symptoms. We know that the Duchenne patient will develop cardiac dysfunction at birth. And the question is, when should these cardiac medications be started? Should they be started at diagnosis, or should they be started at the onset of dysfunction? And I think that's one of the questions that the field of cardiology is tasked to elucidate in the future. So some of the medications that we're going to be talking about today include ACE inhibitors or angiotensin receptor blockers, beta blockers, or mineralocorticoid receptor antagonists. Those are the 3 oral medications that are very commonly used in this patient population. We won't be talking a little bit about an IV drug called milrinone that can be used in patients who have poor cardiac function. It's given through a percutaneous line, and it can be delivered at home for patients who have more severe symptoms. Andreas did a nice job of already talking about implantable defibrillators. I'll touch on that just a very brief amount of time. And ventricular assist devices, which are mechanical pumps used to help with the myocardium, and as well as just a brief slide on transplantation. So ACE inhibitors or angiotensin receptor blockers, often lisinopril, enalapril, losartan are sort of the common ones in this category, are first-line therapies for patients with Duchenne. Data suggests that initiation in patients with normal function may slow disease progression, and that's been documented in the literature. A general consensus without an enormous amount of data has recommended that we start these medications or consider it therapy at or before the age of 10 years. There's a lot of differences of opinion on this, and I think also we need to add this to our list of things to target with regards to trying to get better natural history data and better general consensus. But I think everyone in cardiology would agree that at the onset of dysfunction, these medications should be started. Once these medications are started, we do need to monitor kidney function and your potassium and electrolytes while in therapy because they can impact those important body fluids and cause problems if they get out of whack. Beta blockers tend to be second-line therapy. Those are drugs that oftentimes go by the name of metoprolol or atenolol. They're typically started at the onset of ventricular dysfunction. However, they're used to treat heart rhythm problems and including fast heart rates. And we do know that patients with Duchenne tend to have higher heart rates than patients without Duchenne. And whether or not we should be treating that or not with a beta blocker earlier, I think is a question for further investigation. Another drug that has come to attention, probably more so in the last several years, are mineralocorticoid receptor antagonists. These go by the names of spironolactone, aldactone, eplerenone is one that is pretty much in favor at the moment. AHA, American Heart Association guidelines state it's reasonable to consider starting these medications with systolic dysfunction and or if you see that fibrosis on the cardiac MRI. Eplerenone is the first choice, but spironolactone can be used. Eplerenone is what we call a selective aldosterone receptor antagonist. That's a lot to think about, but what that means is it does not bind the progesterone or androgen receptors, and the most important point of all of that was that it reduces the side effect of drug-induced gynecomastia, so which is can be breast enlargement in boys who are being treated with the drug. And so eplerenone over the more generic spironolactone is considered if you can get your insurance company to approve that. We are now in the golden age of therapeutics, and there are more contemporary heart failure therapies coming online. We'll talk about, here are 4 of them listed. We'll talk about the first 2. Angiotensin receptor or neprilysin inhibitors, ARNIs. We have no data yet on these drugs. Then one of them commonly goes by the name of Entresto in Duchenne, and recommendations currently are based on results from non-Duchenne heart failure trials and from the American and European Cardiac Society's chronic heart failure treatment guidelines. The use of these drugs can be considered in place of an ACE or an ARB for Duchenne patients with very low ejection fractions in the setting of background of guideline-directed medical therapy. So, I think that there's a lot of discussion about the use of Entresto currently in the Duchenne population. I know a lot of families are having questions about the use of Entresto in clinic at the moment. And I think that this is one place that the cardiology community will tremendously benefit from the addition of advanced heart failure physicians coming into this realm and providing care for Duchenne patients. We also can talk about SGLT2I inhibitors. That's kind of a big, long term. And there's, once again, no data for the use in Duchenne. The recommendations are based on adult heart failure treatment guidelines. And again, the use of an SGLT2I inhibitor should be considered in Duchenne patients when the cardiac function is poor in the setting of other medical therapies. Now let's talk about some laboratory monitoring while on these heart failure therapies. There's no guidance regarding appropriate biomarkers to monitor disease. We do sometimes recommend baseline BNPs or pro-BNPs to provide a marker of dysfunction. Troponin elevations, or troponin is a marker of myocardial injury. It's a blood marker that can be checked. It's very difficult to interpret. Clearly, there are baseline troponin elevations that are present in this patient population that sometimes will scare emergency room providers or families. And we have seen troponin elevations that are probably associated with a natural history of disease progression. This is beyond the scope of this conversation here, but it is a potential a marker that we can keep an eye on. So the recommendations for Duchenne patients on drug therapy include an annual sort of basic metabolic panel, a cystatin C, which is used to monitor kidney function to assess those on drug therapy. An annual troponin is very controversial, as I mentioned, and patients who have more significant heart failure obviously will increase their recommendations with regards to the need for baseline and therapeutic monitoring. I'll sort of briefly go over this because Andreas did an outstanding job of talking about ICDs, but it's important, so we'll just briefly review. It's a battery powder device that's placed under the skin, which monitors heart rate and provides a shock when a sustained ventricular tachycardia or fibrillation is detected. It was approved by the FDA in 1985, and newer generation ICDs have dual pacemaker function, and the pacemaker feature paces the heart when tachycardia is detected. ICDs save lives, but it's a delicate risk-benefit balance. They do prevent sudden death, but there can be complications because I think some people have said, well, this is great, just throw one in. And you're kind of like, maybe not so quickly there. Oops, that is not what, can I go back a slide?
It's the red button.
The red button, oh, okay. There we go. Because you can get inappropriate shocks, lead displacement, lead failures, and they do have a psychological impact of receiving shocks inappropriately. So, ICD placement should be undertaken after consideration of the risks and benefits. The data to support ICD placement in Duchenne is limited, as Andreas mentioned. The incidence of arrhythmias is poorly defined, and the incidence of true sudden death is unknown, but currently under investigation. ICDs have been placed in Duchenne and have reported limited appropriate shocks. And as Andreas mentioned, the class 1 indication for ICD placement in adult non-ischemic dilated cardiomyopathy, or adults who have cardiomyopathy not related to myocardial infarction, is an ejection fraction that is low, less than 35%, and has New York Heart Association functional class 2 or 3. And these are not likely appropriate guidelines to place ICDs in Duchenne, but they are all we have at the moment. So at the moment, we just need to monitor for arrhythmias more closely in Duchenne patients with moderate to severe cardiac dysfunction. If patients have symptoms such as palpitations, they should be acknowledged. As we already mentioned, advanced age, the teen years to young adults should bring additional monitoring. And the decision to place an ICD should be personalized and occur only after risk benefits are discussed. And we are really without significant evidence-based guidance, but we are working on achieving that. Just a brief slide or a brief discussion on cardiac transplantation. There's only been a few reports of Duchenne transplant recipients in the literature. More patients with Becker have been transplanted, and transplant outcomes of other muscular dystrophy patients or non-DMD neuromuscular disorders are similar to those without muscular dystrophy, which is reassuring. And I think this can be a consideration in very select individuals for a variety of reasons, and is really beyond the scope of our talks. But I think it's appropriate to realize that it's under discussion now, and people are thinking about it more so than they were a decade ago. There's definitely a need to achieve national guidelines to direct selection and management of patients. And just a brief slide on ventricular assist devices. It's a device that uses a mechanical pump to support a failing heart. And these devices have been placed in select Becker and Duchenne patients as a bridge to transplant and as destination therapy. There are many challenges, however, with regards to placing an ICD in a patient with Becker or Duchenne. It definitely requires an extensive multidisciplinary evaluation. It sometimes can be difficult to find an appropriate surgical pocket to place the device in a patient whose skeletal muscle isn't healthy. There can be delayed wound healing given the underlying muscle disease. The lines or the wires and dressings can complicate physical transfers. And it requires, I think some of the hardest ones are that it requires the family to live near a facility that allows the device to be managed. And it's unclear at this point in time if these devices will prolong the duration or quality of life in patients with Duchenne and Becker, though I think that we are extremely optimistic, and some of the patients who have undergone device placements so far have shown us that this is definitely an option worth thinking about and pursuing. And to come to a close here, let's talk about just a smidge about cardiomyopathy in female carriers. There are definitely more questions than answers at this point in time, and maternal carriers are clearly impacted by cardiomyopathy. The natural history is really, really an area that has been undefined, sort of a plane of snow that no one is, or very few people have stepped on so far, and really needs to be defined. When should we start to be concerned? in these families? Should we be concerned at genetic diagnosis, in childhood, early adulthood, mid-adulthood? I think these questions need to be answered. And PPMD has actually taken the lead in this, providing substantial grant money to institutions to investigate female carriers. And are these women experiencing early cardiac death? I think that's a really important question that we don't know the answer to. Can we impact the disease with early intervention? Should we treat the cardiomyopathy once identified? It definitely highlights the need for genetic testing and carrier identification. And as you can see, lots and lots of questions, and an area that I think we need to address in the next decade. So, in summary, it's an important time in the cardiac care for Duchenne and Becker muscular dystrophy. New drugs are available for the treatment of heart failure, and new therapies are being developed for the treatment of Becker and Duchenne. We need to better define the natural history of cardiac disease, and treatment guidelines need to provide harmonization of care, a term that we heard earlier, and facilitate insurance approvals for these therapies. I think the only way we're going to get insurance approvals is by knowing that these therapies are effective. So making sure that we have that data to allow insurance approvals is important. This data will also help us inform clinical trials. And I think it will, we should work together in networks that you'll hear about from Chet, such as Action, at the conclusion of my talk. So thank you again for this opportunity to talk to you today. It's truly an inspiring time in the care of Duchenne.
Thank you, Linda. Oh.
Restroom break.
Oh. Emergencies are allowed.
Yep.
So Linda, when patients go to the ER with chest pain, one of the first things they say they are going to draw are troponin and BMP. Can you talk a little bit about what those are and why are they important? And
yeah, I mean, I think the BMP is a marker of long-standing cardiac function and heart failure. And so I think, if your BMP is elevated, that means that your heart really isn't doing the job that it needs to do, and that is a significant concern and will definitely require additional treatment and sort of activates the ER-EMS system, so to speak. Now, the troponin elevation is a really, really complex question, and we've definitely had entire meetings on troponin elevation. Troponin is a marker of myocardial injury. So if you have a heart attack and you go to the emergency room and they draw your blood, they'll say, oh, your troponin is normal. That's really good. Your heart is probably fine, but we might send you home. But if your troponin is elevated, then that also calls all the cardiologists into activation. Now, interestingly, in Duchenne, there is probably a troponin leak. And so the troponins are elevated to a mild degree in Duchenne. Occasionally, they're markedly elevated. And we're just really sort of learning to understand what that means. But it's probably a marker of significant myocardial injury or natural disease progression. And so I think that the troponin value is important. I think to understand that it may be mildly elevated at baseline is important to not cause panic in families. But if the troponin elevation goes markedly up, then I think it does warrant additional investigation and work with your cardiologist to figure out why that is occurring.
Thanks.
A long answer, but it's complicated.
It is complicated. Cardiology is complicated.
Yeah.
And gene therapy is complicated. So we are hopeful that the gene therapy will help the skeletal muscle and have great impact on this diagnosis, but we're not sure what it'll do to the heart. So Tim is going to talk a little bit about cardiac implications with gene therapy.
Thanks, Kathy. It's fitting that I'm scheduled after Linda since I've been following her for almost 38 years now. So appreciate the opportunity, the invite to be here and to show our slides and talk about one of my favorite topics since I got a PhD in genetics in 1989 and been thinking about and looking forward to the day when gene therapy becomes a reality for many, many years. So hopefully you guys got my slides and you can load them up. There we go. Okay, so yeah, that's me. I actually am a cancer doctor, but got pulled into the PPMD field and and have been really enjoying the opportunity to help and talk about this topic. So anyway, struggling with technology today. There we go. So I thought I'd start with just a basic introduction. And tomorrow I'm scheduled to give a little bit broader introduction. It'll be a little bit more in-depth, but we're going to hit some highlights today. So if you're interested in this topic, come again tomorrow. I'll have other slides as well, so it won't be a total waste of your time. And we'll be hearing tomorrow morning from the companies that are running many of the clinical trials in gene therapy right now. But basic introduction, you sort of have to understand, go back to high school biology and understand how genes that are in the nucleus of a cell get expressed. And I've diagrammed that here just to give everyone a common framework. The DNA, which is double-stranded, the helix is transcribed, and we'll be using some of these terms so you get to know them, transcribed into a pre-RNA. So it's a copy of that DNA, but it's a little bit different, and so it's called RNA. But that's disjointed. It's sort of like trained cars that have not been linked together. They're all spread apart for a given gene on the genome. And then splicing has to occur to bring those cars together, and that's your messenger RNA, which then gets exported out into the cytoplasm and translated by the ribosome into the protein, in this case, dystrophin. So in the cell with an altered gene, and I've illustrated that by an X, something's wrong with it, a deletion, a change in the base pair, or a duplication that kind of messes it up. The same process occurs, but that X is carried through, the abnormality is carried through, and oftentimes then when it gets to translate it is an abnormal protein, usually truncated, usually shortened. And so the promise of gene therapy is really to correct that back to the cell on the left in some way. And the most common used is getting a gene into the nucleus with adeno-associated viruses, so I was going to focus on today, AAV. And what you can see as I've illustrated here, it's really gene addition. It's not replacing the gene that's already there. It's not editing it. There is ways to do that. We'll talk briefly about that tomorrow. But it's really just substituting in a functional gene that can now do the job after it gets produced into RNA and then translated into a protein. It can do the job. And I called it a normal-ish protein because, as you'll see, the dystrophin gene is just too big to package in AAV, so some smaller versions are used. So just to understand a little bit how that happens with AAV, I thought I'd throw in this slide about how a virus works. We're now all very, very familiar with viruses, but this is an example of where viruses might be able to do some good as opposed to cause a pandemic. AAV is chosen because of its safety. It's not associated with any disease. It's a virus that was just found when we look for viruses in our environment, but it doesn't cause any pathology or any disease. So it's largely been very safe to use, but viruses find proteins or other molecules on cell surfaces to bind and then infect that cell. It goes through what we call an endosome, goes into the nucleus, and then the genome of that virus is deposited into the nucleus, and then in this case, it stays separate from all the other genes in the nucleus. The other genes, as you know, packed in chromosomes, and this is what we call an episome. It's not integrated into any of those chromosomes most of the time. That can happen rarely, as we now understand with AAV, but most of the time, and this was another reason AAV was picked, because it was thought to not really cause any problems in the normal chromosome. But that episomes, that plasmid, that circular DNA that came in with the virus, the genes there are then transcribed into RNA and made into protein. And the promoter that's used that drives the gene, that's a sequence that is recognized by cellular proteins to turn on the gene transcription, sort of determines how much is produced and what cells it's produced in. So that promoter is very important. And different serotypes. So traditionally the word serotype, sero is from serum, and the type. Usually viruses were categorized into different types if someone had an immunity to one virus but not another. Even if it was the same kind of virus, then they had a different serotype. Now we know with AAV that the different serotypes, they're all different by sequences and protein variations on the outer shell or called capsid of the virus. But sometimes if you have an immunity to one serotype, you can have immunity to many of the other serotypes. But there are the possibility, because they are distinct, that you might have immunity to one, but not another. And the different serotypes all have a little bit different biology. So what this slide illustrates is that different serotypes may infect different target tissues different ways or different amounts. And they'll differ in the mouse or the dog than in human, because that receptor interaction with the virus I showed on the last slide really determines which cells the virus goes to. And so you can see that if you look by the different organs on the left and you scan down and you say, well, which ones go to skeletal muscle, or in this case, go to the heart, you can see several of the serotypes listed do, but many of the others that go to the eye or the liver up above are not as favorable going to the heart. Most of these AAVs go almost everywhere. This is a matter of sort of degree and how much. So when we give these AAVs, they're going to a lot of places, but the promoter turns on that gene in the cell where we want it. But the good news here is many of these AAVs go to not only skeletal muscle, but also to heart muscle. So this is what happens. So the AAV genome, the one that's normally in there, if you just cultured what we call wild type, a normal version of the virus out in the world, it's got a couple repeats on the ends called inverted terminal repeats, ITRs, and then it's very simple virus. There's a replication and a capsid gene. And this rep and cap genes are what create that outer structure of the virus when it goes into a cell. But we can get rid of those, and because we can provide that gene in a cell that we're going to grow this virus in, we can get rid of those genes. So it's basically a gutted vector, and vector we use as a term to a virus that we're using to get other genes in. We call a vector, and the R on the title there is for recombinant. So wild type versus recombinant. So recombinant version of the virus is where we've put in our own promoter to turn the gene on, and transgene. Transgene is a word that we use for the gene that we've put in there that we want to transfer into another cell. So in this case, the transgene is going to be a gene that we want to use to change the function of the cell, either dystrophin or there are some other transgenes actually that can be helpful. So you can see that it says up to about 5,000 base pairs, about 4,700 that you can use to package into an AAV vector. But if you look at the dystrophin gene, which is illustrated across the top, the full length is more than 4,700. It's 11,595 base pairs. So it's quite a long piece of DNA, even if you get rid of all those introns and pack all the boxcars together, it's over 11,000 base pairs. So too big for AAV. Yet AAV was very attractive as a vector because of its safety profile and lack of integration into the genome and so forth. And so investigators early on, as you can see, as early as 1997, were putting versions of dystrophin that were shorter into AAV. And these are the illustration of which pieces of the full length that are retained in what are known as either mini or micro dystrophins. So they're smaller versions, but they have thought to have pretty good function. But as some investigators have pointed out, it's not 100% function because it's not totally full length of these different proteins. But you can see the different ones in the Pfizer trial, Sarepta trial, and the Solid trial. There is a potential concern that's been raised because the thought is if, the effort has been all towards skeletal muscle, but if gene therapy works for skeletal muscle fibers more than it works for heart muscle fibers, the concern is that you might put more strain on the heart if the boy's doing more things for a longer period of time, and if the heart's not fixed at the same time, then you might accelerate cardiomyopathy due to increased load on the heart. So the question has arisen, when we give these therapies, how well does it go to the heart? And fortunately, at least in the animal studies, it seems to go to the heart quite well. This is a series of 5 different articles that have been published, actually 6, because there's 2 in the first category, looking at different adeno-associated virus, different serotypes, different genes or transgenes put in there, and then looking at what has it done to cardiac muscle, either expression of the transgene and or function. So you can see the first one across the top in 2016 and 2018, enhanced cardiac hemodynamics. The next one, the microdystrophin, improves systolic function. The GAL-GD2, which is another transgene, it's sort of a surrogate gene we'll mention tomorrow morning that helps improve function. It's not dystrophin, but it can help improve function. Worked on the heart as well in mice. The next one you're going to hear about tomorrow as well, the U7 system went to the heart, and actually I'll show you a figure of that next. And the duplication in mice that's found in exon 2 in some mice, it improved cardiac function up to 40% of wild type. That's actually shown here. Complicated graph, too small for you to see, but the bars on the tallest bars on the right are normal mice. The next tallest bars are dose escalations of gene therapy and the amount of the dystrophin that's being detected in the heart. And you can see that with the red stains. With increasing dose of virus, you get increasing density and expression of the transgene, of the normal dystrophin molecule in this case. So we'll get into a little more detail about that tomorrow. But the good news there is it seems that AAV does transduce the heart, and I think that would be troublesome if it didn't, obviously. So there are 3 major clinical trials now actively enrolling for systemic or intravenous gene therapy clinical trials in patients with Duchenne muscular dystrophy. Summarize them here. They have different serotypes, AAV9, AAV-RH74, and AAV9 again. Pfizer Sarepta Solid I mentioned. There are different phases of studies and different numbers of patients, as you can see, and a little bit of a different age range in each of those. But they're all using a microdystrophin of some sort. And if you want more details about those, you can find them on clinicaltrials.gov. So the data so far, most of the data hasn't been published yet, except first 4 patients in the Sarepta trial, where it looked pretty good in terms of muscle biopsies of skeletal muscle. You can see there the red staining before versus after gene therapy in 4 different patients. What looks like pretty robust expression, comparable to the normal skeletal muscle on the upper left. But cardiac findings are lacking. So if you search that paper for any report of cardiology, they said they did echoes and cardiac MRIs, at months 4, 6, and 12 or something like that. But the only results were about safety. Moreover, results from cardiac magnetic resonance imaging and echo demonstrated no adverse findings in all 4 boards at the time points assessed and were within normal ranges for children with or without DMD. So I'm not sure what that says, actually. It doesn't say much. There's all the kinds of details that you just heard about, kinds of different imaging modalities and monitoring. We have no information about what's happening with these gene therapy trials in the heart, and that's one of Linda's soapbox messages to all these companies. So I'm just going to end on a few. So we've got a lot of hope, though, about gene therapy in the heart, I think, but we're still in really infancy stages. And there are a number of challenges that we need to acknowledge with gene therapy. The first is that these viruses are immunogenic. They can induce an immune response in a variety of different ways, and they are circulating amongst us. It sounds like one of those science fiction shows with aliens, but viruses are circulating amongst us, and a certain percentage of us have antibodies to these viruses already, because our immune system has seen them in one way or another. And so those antibodies can interfere with the ability to get the gene where it needs to be. And so that's one challenge, is the existence of pre-existing anti-AAV antibodies to one serotype or other serotypes. So eligibility testing is a key component of these to accept patients who don't have either any detectable or have very low detectable AAV antibodies. There are other ways that people are looking at to try to temporarily get rid of those antibodies to allow this gene delivery to occur, such as plasmapheresis, where patients are hooked up to an apheresis machine and you can circulate the serum through a machine that removes the antibodies temporarily. Another is using a drug that actually cleaves the antibodies and sort of shuts them all down temporarily. Your body will keep making them, and so the idea is you have a short window of time where you could deliver the virus. Some patients have experienced liver damage. There can be early damage or later damage that's been largely found to be mitigated by steroids. Another way to mitigate the patients with underlying liver pathology already seem to be at higher risk for that. And then there's some vector engineering that can be done to reduce the immunogenicity of these viruses, such as, I won't get into it, but changing the codons that are used to express the amino acids that are less immunogenic. There's something very serious that's occurred in some patients that was unexpected, and that is complement fixation. Complement is part of the innate immune system to fight off bacteria, and if it's aberrantly activated, it can be quite problematic, and patients have ended up in the ICU. But there are anti-complement antibodies clinically available to counteract that, as well as supportive care, and it seems to occur in patients who have gotten the really high AAV doses, and it's not clear whether it happens with all serotypes or not. There is also something that's been described in non-human primates, a dorsal root ganglion toxicity, some toxicity to the nerve cells that supply the muscles, but that's not been seen in any human trials, so we're not sure if that's clinically significant. And then you can not only get antibodies against the virus shell, but you can get antibodies against the dystrophin protein itself, especially if that protein is seen as foreign. So if the patient has is only expressing a truncated version of it or has a deletion of a specific region, then that patient's immune system has never seen those sequences. And so now if you restore the full length or a version that has some of the regions that weren't there previously, those regions can be seen as foreign and an immune response. And that's why there's a strict inclusion criteria for some of these studies based on which sequences are there. And then there is some concern about what we call genotoxicity. We previously thought that viruses did not integrate with the chromosomes and the rest of the DNA, but it has been found to occur at a low rate, that sometimes these adeno-associated viruses do sneak into the genome. Then they become a permanent fixture of that cell, and can activate genes around them. And if one of those genes around them is an oncogene, there's concern that they could cause cancer. And that's been a concern with some of the gene therapies that use viruses that integrate a lot, like lentiviruses that are being used for sickle cell disease or beta thalassemia, but hasn't really been seen yet with an AAV. There is a patient with hemophilia that got AAV, but the liver cancer they developed was thought to be due to hepatitis. There was no evidence that the gene caused it, but it is a theoretical concern. And then there's been at least one patient that had developed a worsening cardiomyopathy after getting viral therapy. And this is a big, heavy load. We give 10 to the 14th particles of virus into patients. That's a big load, and as we know from COVID vaccinations, activating the immune system can be problematic. So there are a lot of questions that remain unanswered in human clinical trials, and I think the problem so far is they've been mainly unasked. So is the transgene expressed in the heart? Obviously, it's much harder to biopsy the heart muscle, but not impossible. But if it's expressed there, and we hope it is, we think it is, based on mouse studies, is it expressed at similar levels to skeletal muscle? And if it's not at similar levels, would that disconnect exacerbate cardiomyopathy? Does gene therapy ameliorate decline in heart function? And if so, in what ways? Might it prevent these troponin spikes Linda mentioned, or the development of fibrosis? Does the expression last as long or maybe even longer in the heart than in skeletal muscle? One of the reasons we think that the expression should last very long is if there's less turnover of the cells, they're going to sit there, that episome's going to be in there cranking out the gene for a long period of time. But we don't know how long. We know that it can last in the hemophilia patients up to 10 years, but in that case, the levels seem to decline over time, and that's thought to because the liver, where those genes are, turns over fairly frequently. or the cells repair, die off and repair, so you lose some of the expression. We don't think that's going to happen as much in the muscle, but it might. And can it be effective in prolonging life in non-ambulatory boys by just improving the heart function? So those are some of the remaining questions. Thanks for your attention. Happy to have any discussion. Got a fan base.
Thanks, Tim. Always fascinating. I think one of my biggest questions is if you do a cardiac MRI on a little guy, like a 4-year-old, and it's normal, and you are evaluating the effect of gene therapy in that very little guy, what would you look for?
Well, that's a great question. I think my esteemed colleagues on either side of me need to figure that out. How's that for punting?
That was really good. That was good, Tom.
Yeah, well, I think that's the problem, right?
Right.
I mean, that is why these trials, to know the impact of the gene on cardiac function, are years in duration. Unless you do the trial in an older cohort of boys. I mean, as these trials move to older boys, I think those questions will be answered in a shorter period of time because the disease is actively more evident. Either we find better biomarkers in the younger kids, or we're going to have to wait.
That makes sense.
And I think the other point that really needs to be defined here is as you expand to that population, if you don't know what the natural history is, the moment you see a change on that MRI, everyone's going to lose their mind. Because then they're going to say, is it the gene therapy? Is this the natural history? Which is it? So this is, it'll get to some of the stuff that we talk about next is we need to understand this right now. We can't wait 20 years to figure this out because these things are coming down the pike. And if something happens in these trials, and obviously something already has in one of them, we have to understand what's going on, what was related to what we see generally, and do these look like that, or is this something different? Because otherwise, we're going to be 5 or 10 years down the road and then say, oops, or no, this is great, this is working, or here's how we do it. We need to know the baseline now, so as those boys come in and as we expand to older populations, we have an idea of both safety and efficacy.
Thanks.
Yeah.
So I don't want to rush Chet's talk, and I know he's got a lot to say, so I think maybe if we take a break now and come back at 5 after 11, that would be great. And then we'll talk about action and how we're aggregating data and learning about natural progression and harmonization and have questions and answers. So thanks, everybody. We'll be back at 5 after 11.